So good morning to everybody. My name is Katalin Hideghéty and I am working here at the University of Szeged as a radiation oncologist. And today the whole day is devoted to laser-induced ionizing radiation, or at least ionizing radiation, and I shall give you an introduction into three disciplines very shortly, because radiation oncology is quite a large discipline. May I close the door, or still we are waiting someone?
We are waiting someone.
Okay.
Yeah.
So, in my first two talks, I shall tell you some basics on the use of ionizing radiation from the part of the users and how important it is for the physicists who are discover something or develop something to know the user's aspect, and thereafter about some basics of hadrons. And I would like to start with the motivation. The motivation is that we would like to cure cancer patients. And the only possibility prior to 1895 was the surgery with different awful methods or improving methods, but the only possibility was to remove the tumor. But after the first X-ray image from Wilhelm Conrad Röntgen's wife hand, something has started in this field, something very interesting. And the X-ray tube has been developed and could be used very fast after the discovery of X-ray. After 3 months, they have used it already against tumors, and after 1 year, already breast cancer patients, 3 breast cancer patients have been treated already. The names are as well as archived of these patients. And 1 year later, the radioactivity has been discovered as well as. So 2 large disciplines have been developed: the radiation oncology, radiotherapy, and radiation imaging, the radiology. I shall speak about the radiation oncology, which nowadays became a completely complex tumor therapy, and it has been developed because of the imaging, because of advanced diagnostics, and not only imaging, but as well as molecular and pathological diagnostics. We know a lot about the tumors prior to decide on the treatment, and the decision is made interdisciplinary with all of the experts of the field, from surgeons to radiotherapists, clinical oncologists, radiologists, and so on. And of course, a very important emphasis has been made on early detection, which is enabled because of the advanced diagnostics. And the therapy itself is very complex. We have to define in time which part of therapy started, and a combination can be used, and a sequence has to be defined in order to get more and more cure rate, more and more prolongation of the life of the patients, and not only prolongation, but qualitative survival has to be achieved, function preservation has to be achieved. And what is the magnitude from the point of the radiation oncology? Around 70% of the patients receive radiotherapy in their cancer history life, and it means 10 million patients per year worldwide who receive radiation in any form of ionizing radiation. And what is the main aim of radiotherapy? To achieve the local regional control, and we use therefore ionizing particles which deposit their energy in mass. So this is the unit of the ionizing radiation, the dose, energy per mass. It is joule per kilogram, the gray. And it starts with a physical process. It can be delivered as a form of teletherapy percutaneously. It can be delivered as a closed therapy, a brachytherapy, putting the radioactive isotope solid material into tumor-bearing cavities or inserting into tumors. This is the brachytherapy, or in the form of solutions via intravenous application. And the first thing which happens is the absorption of this energy and ionization. And thereafter, free oxygen radicals, which are highly reactive fragments of oxygen species, occurs within a very short time, you will see, mainly due to water radiodialysis, but it releases chain reactions and lipid oxygenation and so on are happening and play a role in the different damages. But as well as both due to the very active hydrogen or oxygen radical reactions and the direct effect of densely ionizing radiations, directly the macromolecules can be changed and damages. So in summary, the protein damages, the enzymes may change the metabolical processes, and the membrane permeability increase, change the whole milieu of the cell, mitochondrial changes or damages may occur, lipid peroxidation, and the DNA damage, which is define the fate of the cell, which can go to apoptotic way, and all of these procedures are acting through different pathways, activating inflammatory and pro-inflammatory processes, and the gene regulation and proliferation, multiplication of the cell is changing, and it can lead directly to the death of the cell by apoptotic, by active process, or by killing the cell completely as a necrosis, or just a permanent cell cycle arrest occurs and the cell will older during a short time, senescence arrive, or mitotic catastrophe. And sometimes all of the damages can be repaired. So a summary of all of this process, it starts with energy absorption, free radical building, and thereafter macromolecular changes, which has a consequence of metabolic regulation of membrane and DNA changes. It can be fully or partially repaired. Some of the mutations can stay for a long time, and it is responsible for late induction of secondary cancer, for example. But the majority is happening during a short time or during some years, leading to radiation necrosis or organ function impairment from the point of view of the healthy tissues, and hopefully damage, complete destroyment of the tumor cells and the tumor, which means the tumor shrinkage or complete elimination of the tumor. And at the part of the organism, immunomodulation occurs as well as, and unfortunately, a decade later or some years, 5, 10 years later, the second tumor induction may happen as well as. These effects are mainly local regional, and they mainly happen in the volume which has absorbed the energy. But there are bystander effects which are occurring in the neighborhood where no dose has been absorbed. So it is not in the low dose region, but a part of the radiated region. There are bystander effects because of the communication of the cells, because of cytokines and vessel wall function changes. And the abscopal effect is as well as known. It is a general effect of the whole organism, or it happens far from the place of the irradiation, as well as due to different communication mechanisms. And the scale of this effect is very important because it happens within pico and microseconds that the energy is absorbed and free radicals are created, and thereafter the reparation of the different macromolecular changes takes place during hours, around 6-8 hours is known as the time of DNA repair, and the acute effect, because of inflammatory cytokine release, which looks like inflammatory reactions, and vessel wall changes, permeability increase, which cause edema, occurs during the radiation and some weeks thereafter, and really after all of this process, after some weeks or 3 months or some months, we can see whether the tumor could be destroyed, and after the recovery from the acute side effect, we can see whether the normal tissues has been damaged or not. What is the characteristics of the ionizing radiation? We have to tell, if we speak about the radiation, the particle type. And in conventional radiotherapy, we use always one particle. Photons, electrons, this we consider as conventional radiation, and nuclear particles like neutrons, protons, heavy ions are considered non-conventional radiotherapy or radiation. Sometimes mixed beam occur, but it is incidental. We don't want we did not want in the past, maybe in the future, but for example, a neutron beam cannot produce as a completely clear, only neutron beam. It is always contaminated with photons. But the most important thing is that we have to consider the quality of the radiation, the particle type, if we speak about the characteristics of ionizing radiation. The energy is defining the depth dose of the particle. The intensity is the number of the particles, and the dose rate is the number of the particles per time. Linear energy transfer, as well as a very important definition, which means that during a unit of wave, micrometer, how many energy, kilo electron volt energy is absorbed. And the shorter is this wave, the higher is the linear energy transfer, the more densely ionizing is the particle. Is it clear? Yes, and the more densely, what is the consequences if the particle is more densely ionizing? What do you think?
It destroys tissue.
Yes, in a certain volume, it destroys much more molecules. Yes. And why is the oxygen supply of the cells so important? What is the next step after the absorption of the energy, after the ionization? If we have ions, what is the next step? How the whole ionizing radiation is act? Which chemical process is occurring?
Maybe toxic ion.
No, after absorption of the energy, the ionization took place, and thereafter, what was the next step? The next step is the free oxygen radical formation. And what we need for that? Oxygen. Oxygen. It's clear? And if we have a very densely ionizing radiation, there are much more direct effect is occurring, so we are not so dependent on the oxygen supply of the cell. Is it understandable? So the linear energy transfer is defining how densely ionizing this particle, how many damages occurring in molecules, and especially large molecules in a certain volume. And of course, it has an effect of biological effect. The higher the LET, the higher the biological effect, and less dependent on the oxygen effect. So I would like to show it like this. With a high LET, very densely ionizing radiation causes clustered lesions, and it results low oxygen enhancement ratio and high relative biological efficacy. And relative biological efficacy means that we are comparing the biological efficacy of a certain radiation to a conventional X-ray radiation. And to a certain biological endpoint. It is very important because it can be different if you're using different biological endpoints. And with low LET radiation, which we are using as in the form of photons and electrons in the conventional radiotherapy, we have low LET radiation, and it is mainly acting indirectly via oxygen, free oxygen radicals, and it is has less biological effectivity. The effect of radiation is depending as well as on cell cycles, and the non-multiplicating cells are not sensitive, they are radio-resistant. But even in the replicating, in the multiplicating cells, the late S phase is quite radio-resistant. The G1 phase is has an intermediate sensitivity, and mitotic and the G2 phase are the most sensitive. So there are, for example, complex therapy modalities when we use different drugs in order to stop the multiplication in mitotic phase, and if we apply the ionizing radiation in that time point when it happens, then it will be much more effective. But the real biological effect on a human being is depending on all of this microscopic cellular and subcellular composition of the target organ or the target tissue, tumor tissue, for example, and as well as on factors which is patient-related factors. The tumor size, the tumor type, the vascularity of the tumor, of course, because if there are less blood vessels in the tumor, what happens? The oxygen supply, yes, the oxygen supply is not good, and therefore there are hypoxic regions, and they are less sensitive to the radiation. It is very important how old is a patient, what is the nutrition status, as well as the anemia. What is the problem with the anemia?
Blood cells are
Exactly, the same, yes? Comorbidities, for example, can you say one disease which may influence other medical students? Which kind of disease do you think that may influence the effect of radiotherapy? Okay, it is not easy question. For example, diabetes mellitus. It can, so everything which has a high metabolic impact on the whole organism. And of course, all of the medication had to be considered if we prescribe a dose for a patient. So this is the patient-dependent factors, the cell-dependent factors, and we have to modify, of course, the effect of our radiotherapy by choosing the good radiation quality, the doses, the fractionation and combination, in order to achieve our aim to eliminate completely the tumor, to cure the patient with as much organ and function preservation as possible in a good quality of life, or sometimes we would like only to release the symptoms to palliate the patient suffer. And we have to take into consideration always the price for it, the side effects which occurring in the form of acute reaction during the radiotherapy and some weeks thereafter, and late sequelae which are irreversible, in contrast to acute reactions which are recovering from themselves after the stop of radiation. But the late sequelae is because of cell death, and as an olcus or organ function deterioration will not recover only by reconstructive surgery. And of course we should not forget, especially if we would like to evaluate young adults or children, the tumor induction. And finally, we are defining the therapeutical index, and our aim is always to improve the therapeutical index, which means that to achieve a better tumor response with less side effects, thinking about all type of side effects, and everything is well categorized and defined in the Oncology Society. So I don't want you to learn these shortages, these abbreviations, but this is a complete response, partial response, minimal change, stable disease, progressive disease, local control, the time to progression, tumor progression-free survival, and overall survival. With all of the measures, the survival and local control and tumor shrinkage, which we can categorize and measure, let's say, semi-quantitatively at least, but sometimes quantitatively, and we take it on one side and the other side, the toxicity, which is as well as defined in categories and in a semi-quantitative scale. So what we have? We have different type of ionizing radiation. We can change the dose, the fractionation, and so on. And we can, of course, the change of the dose, achieve higher tumor control probability as we increasing the dose. But unfortunately, as we increasing the dose, the incident normal tissues, which are in the volume, irradiated volume, or in a close neighborhood and proximity, we increase as well as the probability of complication. So all of our efforts is in order to decrease the dose to achieve a certain effect and to increase or to increase the dose which is necessary for complication, or to decrease the complication probability, and with that we enlarge the therapeutical window. What kind of methods existing? We can use radiation modifiers, sensitization, or protection agents. Of course, it should be selective. We don't want to protect the tumor, and we don't want to sensitize the healthy tissues. The fractionation, you will see, this is how we divide in time the radiation. So the radiosensitization is a complex process. For example, I have mentioned already one. What was that? What I have mentioned previously. If I give an agent to stop the cells in mitotic phase, for example, this is a type of radiosensitization. And other type of for example, agents which are causing DNA damage or which stop the repair process, and so on and so on. And it can result supraadditive effect, and I would like to show that in the clinic it is really introduced already as a protocol to give combination of different agents, temozolomide, cisplatinum, and so on, and irradiation in the same time. It can be given the drug weekly or daily, or already molecular biological agents, molecularly targeted agents can be used for enhancement of radiation effect, and there are emerging more and more agents attack mutation, attack DNA repair, which may increase the effect of radiation. So this was the combination, radiosensitization and protection. The second possibility is to optimize the radiation effect, is the optimization in time. The conventional fractionation means 1.8 2 gray per day, but it can be changed. We can use hyperfractionated 2 times per day, but at least there should be 6 or 8 hours apart because of the DNA repair. We let this process go on. And the adaptive, dynamic, chronobiology guided fractionation can be done We can define a weekly dose, and if we don't, if we deliver the radiation more than 5 times a week, on the weekend as well as, it is an accelerated radiation, so during a shorter time will be the same total dose achieved. So we define the overall treatment time, and it is as well as important to define our timing of the radiation in relationship to the other treatments. As you have seen, the combination with chemotherapy, but you can combine the radiation with operation. It can be done pre-operatively, intraoperatively, or post-operatively, and so on. The fractionation schemes, this is the conventional fractionation. The hyperfractionation means several doses per time, 2 or 3 doses per time, and the accelerated is to achieve the total dose during the shorter time, and so on and so on. Recently, we apply the hypofractionation, and you will see why, but we will go in this moment to that to see, because the third option to improve our efficacy is the increase of the spatial selectivity, to deliver our dose much more selectively as previously it was. And it increases the homogeneity of the target, or we can already plan inhomogeneous dose distribution. For example, if you can define within the target volume spaces where there are low oxygen supply, hypoxic region, this region can be boosted, can be irradiated with higher doses. And the tumor control probability will increase, and because of the selectivity of the radiation, the normal tissues will be less involved, and the normal tissue composition probability will decrease, the therapeutic index will improve. The forms of radiotherapy I have mentioned already. The brachytherapy means that we put isotopes. These are solid seeds or little source which is guided via an afterloader device into the tumor, into the hole of the body which is bearing the tumor, or it can be directly inserted into the tumor. It can be, because of the hadron therapy, I take this example, for example, for the eye tumor irradiation. If this is a uveal melanoma, you can sew a cathode on the surface of the eye, which contains in the inner part small pieces of ruthenium or iodine. And this looks like this, and this is how it is sewed on the surface of the eye, and it can be removed in some 10 or some days after, if the dose is achieved. The other forms of brachytherapy which is applied nowadays is the gynecological brachytherapy, using the different cavities of the tumor-bearing cavities of the woman. Then head and neck brachytherapy and breast. And the most frequently used one is the prostate brachytherapy, which can be used in 2 forms, with iodine seeds, which are permanently spaced in the prostate for the life of the patient, and the activity is decreases within 1 month, giving the required dose. And it can be placed by the help of 3D imaging, and we can see the rectum and the bladder, which can be theoretically well protected. And this is the distribution of the seeds, which you can see that not completely geometrically equally distributed, but this is the reality, and this is a very nice application. And this is another method when the different tubes are guiding the small source. This is a high dose rate. With that method, the dose can be delivered within some minutes, and these tubes 15, 20 tubes are inserted in anesthesia. What is the teletherapy? It starts to develop like this. This man was not living very long. Do you know why? Yes, he's exposed to the radiation, of course, and he does not have any radio protection. And at that time, there were no radio protection rules established very well. But what you can see that this device, this X-ray tube, practically has not too many options. It has one field size and a little bit. If you change the screws, you could change a little bit the direction. But one field size and of course a certain energy, which was quite low at that time to using X-ray tubes. Some tens of kilo electrovolt was the X-ray energy. And later on, and it is not in the very old past, I've used this machine as well in 25 years ago, this orthovoltage machine. You could have a little bit more flexibility, around 5-6 field size, and the X-ray energy of 200 between 300 keV, which is a little bit better. But nowadays we are using, of course, linear accelerators, which provide us electrons or photons in mega electron volt for 6, 10, 15 mega electron volt energy range. It can be turned, the gantry can be turned completely around the table. The collimator can be changed from 2 by 2 centimeter to, or even less, from 1 by 1 centimeter to 40 by 40 centimeter. And it can be turned as well as rotated, and the small leaves are providing us 2D shaping of the tumor. So actually, this technique has been introduced in the late 70s and developed further recently. And nowadays, the conventional photon and electron radiation has reached its top, its maximum of selectivity and accuracy, resulting in a very good effectivity of radiation delivery. You can see the 3D conformal radiation, the intensity modulated radiation possibilities. This is a robotic arm with 6 MeV photons, and it can deliver with pens-seal beam the radiation from 1,200 directions. And even there is a possibility to control and follow the movement during real time, during the treatment delivery, and the movement of this robotic arm can follow, for example, the breathing movement of the patient. This is a type of rotating intensity, rotating arcs, intensity modulation, stereotactic radiation, tomotherapy, and image-guided possibilities to control the delivery during the radiation. With all of this technique, we can achieve dose delivery of a millimeter accuracy. And there are other possibilities developed in the same time, the different type of photon therapy, and the charged particle therapy has a so selective dose delivery that we can go a magnitude lower. We can deliver the dose in sub-millimeter accuracy.